All right, today we're jumping right into a really important meta-analysis from the journal European Neuropsychopharmacology. What this paper does is unpack the fascinating and super important link between medications for the mind and the autonomic system that, well, runs the heart.
And that, right there, is the central question. You know, when we prescribe a medication for depression or anxiety, what are we actually doing to that person's underlying cardiovascular risk? Are we helping it? Are we hurting it? Or is it a wash? The answer, as you can imagine, has huge implications for patient safety and for how clinicians pick the right treatment for the right person. So this gets to the core of the heart-brain dilemma. We've known for a while that conditions like depression are tied to this thing called autonomic dysfunction. Basically, it means the body's protective, rest, and digest signals get turned down, and the stressful fight or flight signals get cranked up. This imbalance is a known pathway to serious heart problems. So, the big question this study asks is, do our treatments help fix this broken connection, or do they maybe make it worse?
Now, to really get what this study found, we first need to understand the language the heart uses to tell us how it's doing. And that is the language of the autonomic nervous system, or ANS.
Think of your ANS as having basically two settings. You've got the parasympathetic system, which is the body's brake. It's all about calm, recovery, protection, rest and digest. And then you have the sympathetic system, which is the accelerator. That's your stress response, your fight or flight. In a healthy person, there's a nice, flexible balance between the two.
What's really cool is that we can actually measure these systems. We can look at the parasympathetic brake by measuring something called heart rate variability, or HRV. The higher your HRV, the healthier and more resilient your heart is. And for the sympathetic accelerator, we can measure skin conductance response, or SCR. Higher levels there mean more physiological stress and arousal.
Okay, let's dive into the findings. We're going to start with one of the oldest classes of antidepressants, the tricyclics, or TCAs. And right out of the gate, the data gives us a very clear warning.
Yeah, the results from the meta-analysis here are just crystal clear. What this chart shows is that TCAs have a big negative effect on all the key measures of heart rate variability. To put it simply, the more these bars dip into the negative, the more the drug is literally suppressing the heart's protective brake.
So, what's happening here? Well, it's a mechanism called anticholinergic blockade. What that means, in simple terms, is that TCAs directly block the nerve signals that tell the heart to calm down. It's like cutting the brake line. For any patient who already has heart issues, this is a clear and measurable risk.
Okay, next up, let's turn to the most prescribed antidepressants out there, the SSRIs. And this is where the story gets way more complicated. It's what we can call the SSRI paradox. The whole puzzle with SSRIs comes from the fact that you get totally different answers depending on how you study them. If you look at simple before and after studies, you get one story. But if you look at the more rigorous placebo-controlled trials, you get a completely different one. So in these pre-post studies, where you just measure a patient's heart function before they start the medicine and then again after, SSRIs seem to actually increase heart rate variability. This points to an indirect benefit. Basically, as the person's depression gets better, their autonomic system just naturally recovers right along with their mood.
But, and this is a huge but, when you isolate the drug's direct effect in a trial against a placebo, the data flips completely. The SSRI molecule itself is linked to a small but statistically significant reduction in that same protective HRV marker. And that's the paradox. The overall treatment helps the system, but the drug itself might have a slight suppressive effect on the heart's brake.
So the HRV part is complicated for sure, but there's a very clear finding on the other side of the system. In those same rigorous trials, SSRIs consistently and significantly reduce skin conductance. What this means is they reliably turn down that sympathetic fight-or-flight response, which calms the body's overall stress level. That's a clear win.
And this is absolutely critical. When the researchers looked specifically at vulnerable patients, people with heart failure or who just had a heart attack, SSRIs had a neutral impact on their HRV. The big takeaway is that they just don't pose the same risks as TCAs, which makes them a safe first-line choice for these high-risk folks.
All right, so let's look at some of the newer antidepressants on the block to see what their profiles tell us about the future of this whole heart-brain connection. One of these newer drugs, agomelatine, really stands out. The meta-analysis found it was linked to a significant increase in high-frequency HRV.
Now, unlike the mixed bag we saw with SSRIs, this suggests agomelatine might have a direct cardioprotective effect. It seems to be actively boosting the heart's protective brake, which could be because of its unique effect on melatonin receptors.
For other drug classes, it's kind of a mixed bag. SNRIs, like venlafaxine, tend to have a risk profile that looks a lot like the older TCAs. They lower HRV. Other drugs have some mixed or just limited data, which really just tells us we need more research on them.
So after going through all this evidence, across all these different drugs and studies, what's the actual take-home message for doctors and for patients? What is the clinical bottom line?
Well, this meta-analysis gives us a really clear framework. On one end of the spectrum, you've got TCAs and SNRIs, which present a cardiovascular risk because they lower that protective parasympathetic tone. In the middle, you have the SSRIs, which are comparatively safe and have that clear benefit of reducing sympathetic stress. And then, on the other end, you've got agomelatine, which shows the potential for an active benefit by actually increasing parasympathetic tone.
And this all translates into a pretty clear clinical decision guide. Number 1, for patients with cardiovascular risk, SSRIs are your first-line choice. Number 2, you should avoid TCAs in anyone with a known heart condition. 3, we should start thinking about monitoring HRV as a biomarker in high-risk groups. And 4, we should be looking to the future, where drugs like agomelatine might be used specifically to improve a person's autonomic health.
Ultimately, what this research really does is move us toward a more integrated field, something you might call cardiopsychiatry. It really drives home a fundamental principle. Treating the brain should never, ever come at the cost of the heart. With modern medications and a clearer understanding of how they work, we're getting better and better at protecting both at the same time.